Interventions with a King. Discussion and commentary based on articles from JACC, Cardiovascular Interventions.
Hi, good morning. I'm Dr. Skip Anderson from the University of Texas in Houston, Associate Editor for JACC Interventions, and I'm here this morning interviewing Dr. Eric Horlick from Toronto General Hospital in Toronto, Canada, on his research paper, soon to be published, Percutaneous Pulmonary Valve Implantation in the Young, with 2-year follow-up. Good morning, Eric.
Good morning. Thanks, Skip. It's a pleasure to be here.
Yeah. Could you tell us some background on this paper, what it was you set out to accomplish?
Sure. So, just as some general background, infants born with tetralogy of Fallot undergo repair usually quite early in life. And for some technical reasons, some of those infants are treated with a conduit from the right ventricle to the pulmonary artery. And the unfortunate circumstance is the natural history of a conduit is that it fails and either becoming stenotic or regurgitant, depending on what type of conduit is implanted. The problem lies in that the conduit will require replacement at a number of times during the person's life as they grow. And so really, transcatheter pulmonary valve implantation developed in order to reduce the number of surgeries required over the time period of someone's life.
Yeah, I see. So at what age did the children you studied, at what age did they undergo their first surgery?
Usually within the first 2 years of life.
I see.
And about 60% of them had more than 2 surgeries by the time they had their transcatheter pulmonary valve.
I see. And at what age did these young people undergo their valve implantation?
Our cutoff was over the age of 5, but if you look at the numbers, it's actually the average age of patients treated was 15, and their average weight was 60 kilos, so very close to adult size.
I see. Adolescents.
Adolescents, that's right.
I see. And how many patients were there in your group?
28 patients.
28 patients undergoing this pulmonary valve implantation technique.
That's right.
I see. And what valve was this that you used? Was it commercially available?
So the valve was available initially on a program called Canadian Special Access, which is a way to obtain access to medical devices that are not yet approved. And then soon after that, within a year, the device actually became available and approved in Canada.
I see. And these children, as they move on into adolescence, and these valves or their surgical techniques are beginning to deteriorate, did they develop a lot of symptoms, a lot of limitations?
It's remarkable, actually, what's going on inside and the impact on their exercise and day-to-day functioning. Generally speaking, all of these patients were symptomatic. They had reduced exercise time and tolerance. And the scary thing is that if you looked at their ventricles, they were significantly enlarged, their right ventricles, that is. And as a consequence, because of the diastolic load on the right ventricle, the left ventricular filling is hampered. And as a result, their cardiac output and their exercise performance is quite limited.
I see. And so after these young adolescents, average age 15, had this valve implanted, how did they do? I understand you had 2 years of follow-up on them.
They did remarkably well. There was an 80% freedom from surgery and about an 80% freedom from reintervention. And the reinterventions that they had were often to simply redilate the valve with a balloon, not place a second valve. Only 2 patients had surgery afterwards. And the surgical group, one was because of stent fracture. The bare metal stent that was placed before the valve was put in, and the valve itself had fractured and required re-replacement. The conduit required re-replacement. And in another patient, the valve function was actually normal, but there was branch pulmonary artery stenosis that didn't respond well to interventional therapy, and the child subsequently had an operation to fix that problem.
I see. And you had some rather elaborate data with echocardiograms and other studies showing improvement in physiological status.
So we showed in a group of patients that had not been treated before, specifically those with previously implanted surgical valves or valve conduits, that we could achieve very good results. And in fact, we saw reductions in right ventricular end diastolic volume. We saw increases in right ventricular effective stroke volume. We saw increases in left ventricular cardiac output and left ventricular ejection fraction, as well as left ventricular gains in left ventricular end diastolic volume, which are all important measures of improvement after pulmonary valve implantation.
I see. So, Eric, in our few remaining seconds, tell me, do you think this is going to have a big impact on clinical practice?
I think that this is going to have a big improvement on clinical practice. The issue, of course, is that it's a minority of patients who actually are treated with a valved conduit after their initial repair or during their initial repair at surgery. Mm-hmm. The far larger group of patients are those with tetralogy who have very large and patchless outflow tracts. And the future of this technology is really the ability to stabilize a transcatheter valve in this large outflow tract. The first patient's already been treated in the UK, and I think there's major technical evolutions that are actually going to come in the very near future that are going to allow us to treat this much larger group of patients, and that is going to be a major game changer. No doubt about it.
I see. Well, thank you very much, Dr. Eric Horlick. I'm Dr. Skip Anderson with Jack Interventions. Thank you.
Thank you very much.